Thank you very much for joining. This afternoon and evening, we're going to be talking about lung ultrasound. It's the talk that I prepared for the Department of Pediatrics, but it's also an old talk that I've done on lung ultrasound. So we're going to be talking about lung point of care ultrasound, specifically really just an introduction to lung ultrasound. So I'm sure you guys know that I'm an ultrasound POCUS fanatic. I love using ultrasound as part of my clinical care, and I'm sure that you guys do too. I've seen that people in our unit have been discovering really cool cases and using ultrasound to help them make diagnoses. And ultrasound is definitely something that we should all get better at. So when we're looking at lung ultrasound, Daniel Lichtenstein is one of the fathers of lung ultrasound, and he described the blue protocol. So the blue protocol is something that you can do when a patient is going blue. So they're in severe respiratory distress, respiratory failure. We are worried about there being some underlying pulmonary or lung pathology. We can go ahead and do a lung ultrasound. And there are various protocols that have been described over time, but Daniel Lichtenstein's was probably one of the best descriptions of lung ultrasound and the features that we look for. When you have a look at lung ultrasound, it hands down outperforms a chest x-ray every single time. When we compare ultrasound to the gold standard is CT scanning. Obviously, we can't do a CT chest for every single patient. We don't have access. At Rahima, it's very difficult. We don't even have a functional CT scan at the moment. We do usually have access to X-ray, but sometimes we have to wait, especially if it's a bedside X-ray, it might take time. Whereas ultrasound, we do have rapid and easy access to pretty much all the time. When you look at how lung ultrasound compares to CT scan, for various diagnoses, for example, pneumothorax, interstitial syndrome, alveolar consolidation, pleural effusion, you'll see that ultrasound is pretty much on par with CT scan of the chest. So it is a great tool to get comfortable with. What probe do we use? Well, we use the linear probe, which is the high frequency, and it shows superficial structures in a high amount of detail. So that's the probe that you want. However, you can do lung ultrasound with any probe. You just are probably going to have to change the settings significantly. So you can still do lung ultrasound with a curvilinear abdominal probe. Even with the cardiac probe, you can still have a look at lung sliding and have a look at the lungs. But we do like to see a fair amount of detail. Where do we do the ultrasound? So in a smallie, we'll probably divide the chest up into 3 zones, the upper zone, the lower zone, and the lateral segment. Ideally, we should be investigating every single rib space, so every single intercostal space, to have a look at what is going on in the lung underneath. We don't necessarily have time for that. So the bare minimum is 3 zones. However, you could divide each of the zones, so the anterior zone into upper, middle, and lower zone, the axillary area into upper, middle, and lower axilla, and the posterior thorax into upper, middle, and lower zone as well. So it really depends on the amount of time that you have. But just for a quick look, we'll at least compare the upper zones on the left to the upper zones on the right, the lower zones on the left to the lower zones on the right, and the same thing in the axilla, so that both of the lateral segments. It's the same when you are auscultating a patient. You'll listen to lung sounds on both sides. You'll compare one side to the other side. So we need to do the same with ultrasound. So when you got a kiddo, where are we putting the ultrasound? Well, we're having a look anteriorly. You'll slide your probe down the chest. We'll look in the axilla. It's really easy for us to have a look at the back, the posterior thorax, because the kiddy is easy to examine. You can examine them in the seated position on mum's lap with an ultrasound. They don't have to be lying down, but obviously if they are ventilated, intubated and ventilated, you'll need to examine them with an ultrasound however they are, but it is still fairly easy for us to turn a child over and to have a look at the back. So we'll have a look at the intercostal spaces to look at the lungs over the posterior thorax as well. This is a very complicated looking algorithm, and this comes from the Lichtenstein Blue Protocol. And it looks fairly complicated, but I'm going to break it down, and there might be a whole bunch of words on here that you don't necessarily understand, but I'm going to break it down so that hopefully it's a little bit easier to understand. When you are doing lung ultrasound, it is a good idea actually to have an old machine. Why do I say that? We love having a new ultrasound machine when we are looking at most pathology. But when you are looking at lung ultrasound, so if you've got an old, crappy, broken down machine that's been donated and it's a hand-me-down. So I learned lung ultrasound on an ancient machine at Helen Joseph called Betsy. It was a third hand-me-down from various departments. And she was the best for lung ultrasound because the artifact on this ancient machine was great. And when we're doing lung ultrasound, we actually want artifact. So you'll often need to go into your settings and choose lung ultrasound, specifically because it's amplifying the artifacts. We don't want to get rid of them. So often when we're doing other parts of the body, you want to get rid of the artifacts. But when you're doing lung ultrasound, we want artifacts. Obvious things that are helpful is to understand that gas goes towards the sky and fluids towards the earth. So it just depends on how the patient is lying. If the patient is sitting and you're worried about a pleural effusion, obviously it's going to go more towards the diaphragm and towards the toes if the kiddie is in a seated position. If the child is supine, then the fluid is going to collect more towards the back. Same with the pneumothorax. If the child is seated upright, we'll probably see the pneumothorax and the absent lung sliding and even the lung point right towards the apices. Whereas when the child is lying down supine, we'll often find it anterior on the chest. So where are we doing the ultrasound? So I've already described this, but at least compare the left to the right each time. Usually it's a good idea to start in the mid clavicular line, move across to the mid axillary line and move your probe across to the posterior axillary line and try and go as far to the bases as possible as well. So what are we looking at here? We are looking at lung sliding. So just the little arrows pointing out a white hyperechoic mobile line. And that is what we're looking for. We're looking for lung sliding. So what we're doing is we can't actually see the parietal and visceral pleura rubbing against each other, but that is what we are seeing when you are seeing lung sliding, the pleural line. So just to orientate us on the screen, up here we are seeing skin, some subcutaneous tissue, some muscles. This is the pleural line, which is the parietal and visceral pleura rubbing against each other. This black shadow here is a rib. That black shadow on the edge of the screen is also a rib, and the shadow behind is a rib shadow. So this is what we are looking at when we first start doing lung ultrasound. We're trying to interpret artifacts. So if there's a pneumothorax, if there's air in between the parietal and visceral pleura, there's interference with lung sliding. You cannot see the air on a lung ultrasound. However, you will have an interruption of the normal lung sliding. What do I mean by we're interpreting artifacts? Well, because we can't actually see the air, you can't see the pneumothorax. You can't visually see the pathology. However, we can interpret artifacts. And this is something that's not new to us. We're used to interpreting artifacts. For example, if we're looking at an ECG, we can infer a lot of information about the state of the heart by looking at the ECG. This is an artifact that is produced when we do an ultrasound, showing us the depolarization and repolarization of the heart. And it can give us a lot of clues about the rhythm, about the size of the chambers, about the condition of the valves, electrolytes, all sorts of things. It can give us a lot of information, but we're interpreting an artifact to give us an understanding of what is happening with the heart. So much the same thing when we are doing lung ultrasound, we're interpreting artifacts. So lung sliding is equivalent to sinus rhythm on an ECG. And we like to have sinus rhythm on an ECG. It tells us that everything's okay. So when you're seeing lung sliding in a specific area, that's also telling you that everything is okay. We want to see lung sliding. So then we need to also analyze the lung sliding, right? Okay, so it might be called the ants marching sign. If you can imagine a whole little row of tiny white ants marching, that pleural sliding is equivalent to the sinus rhythm. So it tells us that everything is okay, the patient is breathing nicely, and the parietal and visceral pleura are rubbing against each other in a good fashion. If we were to drop a normal M mode, so a motion mode, through this particular view that we've had here. So if you were to drop M mode, so this image that we're seeing here is called B mode, which is brightness mode, not basic mode. So B mode stands for brightness, but it essentially stands for normal 2D with a grayscale. So this is a fairly standard view that we get when we're doing lung ultrasound. If you drop the M mode, so the motion mode through, we will see something called the sandy beach sign. And you would imagine that the shoreline would be the pleural line. So this is what it looks like, and it's essentially a snapshot. And you can imagine that this would be the sea. Over here is the edge of the shore, and here's a very granular sort of appearance to what is happening behind. So what is the M mode? The M mode is motion over time. So it's showing a specific area and movement. So when the pleura are sliding, this is the view that we get, and it's called the sandy beach sign, which is reassuring. And that's an M mode. If we drop an M mode through a pneumothorax, you'll see something called the barcode sign or the stratosphere sign. So this is an image of us dropping an M mode through the lung sliding, and you can see these horizontal stripes. We've got the loss of the granular structure, the sandy beach behind the sea. And the whole point of M mode is just, it's a nice mode to help us have a look to see what is happening. M mode is used quite a lot by cardiology when we are looking at valves, when we're looking at vessels. Also, M mode is used by obs and gynae as well. And it's a mode that is actually really helpful to us when we're trying to document what is happening. Medico-legally, we're always supposed to document. So we're supposed to save our images. And in a first world setting, we would save the images. It would get uploaded to the patient's electronic file, or we would download it onto a flash drive and it would get added to the patient's clinical notes. M mode is a way that we can take a snapshot of the lung sliding. So if you saw this would tell us there's absent lung sliding, the stratosphere or barcode sign. Whereas if we saw this image, that would tell us there was lung sliding. So this is good, and that is bad. All right, so if we take a still image, it's really difficult to take a still image of lung sliding. So the motion mode with the still image, you could print it out, or if you've got a thermal printer as well, you can print this out, and it shows absent lung sliding. So here is a live ultrasound that is being performed, and you can see on the right-hand side of the screen, there's really nice lung sliding, and on this side, there's absent lung sliding. This here is what you would see when there was a pneumothorax, but absent lung sliding is not diagnostic of a pneumothorax. Lung point sign is, and you can see this is where the lung sliding is in contact with the absent lung sliding. So lung point sign is pathognomonic of a pneumothorax. You might see something called a bat sign. You have to use your imagination. So a bat sign is just described in the literature, and it's showing the intercostal space. So if you were to imagine this was the pleural line, there your your ribs with the shadowing behind, you could almost imagine they were like capes or like the wings of a bat. You really do have to use your imagination. If you see bat sign described, it's just describing the intercostal space. Okay, so what are A lines and what are B lines? A lines are horizontal lines that are reverberation artifacts below the pleural line. And it usually is talking about aeration. It's normal to have a couple A lines. And if you have a significant A line profile, that means you've got fairly dry lungs. Or if you've got multiple A lines, we often see that in a hyperinflated patient. So for example, a child with chronic lung disease, chronic obstructive lung disease, maybe they were an ex-premi that was ventilated for a long period of time, or an asthmatic patient that's hyperventilated. B lines are lines that extend from the pleural line all the way down. Now, lung rockets are also small little lines that come off of the pleural line. It's normal to have lung rockets. Everybody that's alive has got a little bit of fluid in the lungs. So lung rockets are normal. However, when you have many, many lung rockets that are extending all the way from the pleural line to the edge of the screen, and if you've got multiple B lines, that's abnormal. So that's pathology, right? So an A line profile is where you have horizontal stripes, and B lines are where you've got the stripes going from the pleural line all the way to the edge of the screen. This is a video of B lines, and you can see there's the pleural line. We've got pleural sliding and multiple B lines. They're almost like flashlights going all the way from the pleural line extending to the edge of the screen. It's almost like somebody's shining a torch from the pleural line. And in this image, you can see there's multiple B lines. Actually, some of them are even confluent. We need to be worried about significant fluid in the lungs when we see this. So if you see somebody describing an A lines or A profile, those are dry lungs, and the A lines are showed here horizontally. B lines often seen in edema or wet lungs, interstitial or even alveolar fluid. So that tells us the lungs are fairly wet. C lines is where we very well might have small consolidations that you'll see, or large consolidations from the pleural line. And then confluent B lines, so much so that they might even call it a C line consolidation. And we'll often see this image here, for example, in a viral pneumonia. So we saw a lot of this in COVID, when we had lots of small subpleural consolidations. And then you see this confluent area of B lines behind the consolidation. And some people might call it a C line. Personally, I just call it consolidation. Okay, so just to remind us, A lines equals air, B lines equals fluid, and C lines are consolidation. So if now we also need to have a look, and you'll look at different parts of the lung. So if you are looking at a B line profile, for example, if there are multiple B lines in multiple lung fields, so a B line profile where you've got more than three or more B lines in 3 or more fields that you are looking at. So if you've divided the chest into sort of 3 fields on each side, the superior and inferior and then lateral area, so you'll have more than 3 B lines in more than 3 lung fields. That's telling you that there's surely a certain amount of fluid. For example, pulmonary edema. You might have an area of localized B lines. For example, in a pneumonia, might be a consolidation in one area with some B lines. So you need to have a look at that. This is an example of how a little lung rocket will look. Here's some A lines. And in pneumonia here, you can see there's a subpleural consolidation. And the sensitivity and specificity of these specific signs are very high. So they're very reliable and much better used to diagnose lung pathology than on an X-ray. You might hear a term called PLAPS, posterolateral alveolar and or pleural syndrome. And this is described by Daniel Lichtenstein. I hate this term. It essentially says, have a look at the lung basis. And at the lung basis, we're looking for consolidations. You might find some fluid and what the consolidated lung might look like. But it's telling us, don't just look at the anterior ribs. Don't just look at how the lung sliding looks. Do go have a look at your, just above your diaphragm, have a look and see what's happening at the lung bases. So this is a really nice image of a jellyfish sign. This is something that Taylor and I were looking at the other day. We had a patient with a very big pleural effusion. And you can see here is the white line of the diaphragm. There is the liver underlying it. There's significantly consolidated lung. It's almost hepatization. So it's got the same texture as the liver. So it's showing consolidation. And there's the significant anechoic fluid, so significant pleural effusion, and the lung flapping around like a jellyfish. So I really like the jellyfish sign. It's a cool sign, and it's a great one that you'll see in big pleural effusions. This also is telling us there's a large volume of a pleural effusion here. Okay. You also might hear some other terms when we are looking at lung bases. You might hear something called Schweed Sign. So this tissue-like appearance that's indicated by the dark arrows is known as Schweed Sign. So from the consolidated lung to the lung tissue underneath, it's another sign of consolidation, and you very well might find it in pneumonia. Here you can see this black area here, the anechoic area is showing a pleural effusion. And so we're using terms like hepatization to describe how the lung is so consolidated it starts looking like an organ, for example, liver-like tissue. The Schweed sign we will find in, for example, a pneumonia, and very often you might find a parapneumonic effusion like what is happening in this image. Here is another picture that is found in an anterior rib. So we like to look laterally for pleural effusions at the bases because fluid goes with gravity and sinks. This is called quad sign. You might have such a big effusion that you even see the effusion anteriorly over the anterior chest. If you drop a B mode an M mode through one of these anterior ribs, or even laterally, you very well might see this called sinusoidal sign. And this is also one of the signs that you can find for a pleural effusion. It's just describing the movement or the appearance of the movement of the pleural fluid as you're breathing. Okay, so much like you can have air bronchograms on a chest x-ray, we can also have air bronchograms on lung ultrasound. So if you look at the air bronchograms on the right, they're almost twinkling at us. Those are called dynamic air bronchograms. Those are much more likely to be present in a pneumonia. When you've got static air bronchograms, that might be present, for example, if the patient has got consolidation or contusion. It's a little bit more difficult to really tell the difference between static and dynamic air bronchograms, but you can definitely see how the little white hyperechoic dotty appearance of the consolidated lung is underneath in the lung tissue. And this is a good sign to show us consolidation in the lung tissue. And so if you have a patient who's got a dense pneumonia, for example, or a really dense pulmonary contusion, you might see this in the lung underlying the area that's injured or has pathology. I've got a very smart friend, Dr. Craig Beringer, who broke down lung ultrasound a few years ago in a wonderful talk. He's one of my inspirations when it comes to lung ultrasound. I learned a lot from him. And he tried to make Daniel Lichtenstein's Blue Protocol easier to understand. And he did. So this is from his presentation. If you have a patient who's got significant A-line profile, there's a few diagnoses. A-line just means a normal aerated lung. So you might have a normal lung. If there's significant A-lines and it fits the clinical picture, you might have a patient who has got asthma or significantly hyperinflated. You also might have a patient that has aerated lung but has a pneumothorax, but then we'll also look for other features of a pneumothorax. For example, absent lung sliding, and you'll go and also look for the lung point sign. You might find that a patient with an A-line profile has got a pulmonary embolus. So you'll need to also go and have a look clinically at the patient. We don't just look at the lungs. You'll also look at the legs. You'll have a look at the veins and see, is there anything going on there? Maybe you see a small area of consolidation in the area with the pulmonary embolus. So we look for a few features. We don't just say that an A-line profile is hyperinflation. There can be a few differentials. Much the same with an acutely dyspneic patient with a B-line profile. There's a few differentials. First one is pulmonary edema, so it might be cardiogenic. The patient might have heart failure, so acute decompensated heart failure for whatever reason. Might be a young patient with myocarditis, and they might have a subsequent pulmonary edema. The patient also might have a lung contusion. They might have ARDS, especially if it's all over the chest. If there's a significant B-line profile, but maybe in the one area where you're hearing crackles or you're hearing specific sounds that are leading you towards thinking that there's pneumonia. maybe there's more B lines in that specific area. But we essentially B lines is telling us there's increased interstitial fluid or even increased alveolar fluid. So we might also find it in pulmonary fibrosis. You can't look at the lungs alone. The lungs are connected to the rest of the patient. So we always look at cardiac pulmonary interactions. So if you're doing a lung ultrasound, you need to think about the interconnectedness. The patient probably needs to also have a cardiac examination and cardiac ultrasound. And we'll also probably look at the veins as well. So we want to see how is the patient's lungs doing. If we're worried about dyspnea and we think maybe there's a PE, you're definitely going to have to look at the heart and the veins. If we're looking at, is the patient fluid overloaded, you're going to need to look at the IVC and the heart as well as the lungs to try and make a decision. So this is another graphic representation of the blue protocol. I still prefer Craig's way of describing it. I think it's much easier. But in here, you'll see they have a look to try and see is there cardiogenic pulmonary edema, is there pneumonia. We very well might go ahead and do a DVT ultrasound to have a look and try and decide is there a DVT present. Maybe we're looking at a PE. Is there a PLAP syndrome, so the posterior lateral alveolar syndrome with a consolidated lung and pleural effusion? Maybe we're looking at ammonia. If it's absent and there's a significant A-line profile, maybe we're dealing with asthma. Okay, lung point with an A profile, maybe we're looking at a pneumothorax. There's something else. There's lots of protocols, even for lung ultrasound. So you might do a false protocol where they are trying to decide what is the reason for the shock. Does the patient have obstructive shock? Do they have cardiogenic shock? Do they have hypervolemic shock? So we'll have a look at the lungs as well as other parts when we are trying to assess how the patient responds to fluid. So we very well might do lung ultrasound before and after giving a fluid bolus to help us decide how to manage and what the diagnosis of the shock is. But just to, I don't need you guys to understand this in too much detail, just to understand that you won't ever examine only a patient's lungs, you'll examine the whole patient. And it's the same when you're doing a point of care ultrasound. You'll do it as part of your clinical exam at the bedside. It's not a separate investigation. It's helping us to make a decision about the patient there and then. So we'll probably ultrasound the lungs, have a look at the heart, look at the IVC as well. So we don't only use lung ultrasound to diagnose a pneumothorax and trauma. We very well might use it to, sorry, I just want to show you that again, darn. There we go. Sorry about that. You might also be able to see the rib fractures. So here's showing a sternal fracture. So have a look at the continuity of the bone. If you see a break in the continuity, this is the quickest and easiest way to diagnose a fracture. So actually, while you're waiting for x-rays in a trauma patient, if you want to have a look and see is there a fracture, don't be scared to have a look with your sonar. This is a patient who's got a large hematoma with a rib fracture as well. There's the fracture, the white bone doesn't have continuity and there's a big hematoma. So it's another thing that you can do with your lung ultrasound. If you've ever heard of E lines, please, you're probably a special person. There's lots of lines in lung ultrasound. This is not an area of, it's not continuous. You can see this line is not pleural sliding. Actually, these E lines are showing surgical emphysema. I must be honest, clinically, I diagnose surgical emphysema with my fingers. You can feel it. It feels like Rice Krispies, but it can interfere with your underlying lung ultrasound because it makes it really difficult to see the pleural line. So this is also something that can be diagnosed with ultrasound, is surgical emphysema. And you'll see I can't even see the underlying pleural space and pleural sliding because the surgical emphysema is interfering with my view. We might use lung ultrasound for very advanced applications. For example, in ICU, there's all sorts of things that we like to use lung ultrasound for. For example, we'll use it as part of a way to have a look at our diaphragm function. So this video is showing us how the diaphragm thickens and contracts with normal diaphragm function. When a patient has been ventilated for a very long period of time, you can get diaphragmatic dysfunction. And it can lead to weaning problems and problems with extubation. It's one of the reasons why we don't like to ventilate a patient too long. The images are just trying to show us what are we looking at. And you can see the lung sliding in and out of view here. But you can see the diaphragm, these muscles are not thickening and shortening and changing as much as the previous image. So this here is showing us diaphragm dysfunction. Gets really fancy. You can measure the excursion and measure the improvement of lung function by doing specific measurements in ICU. We can also use lung ultrasound to assist us with recruitment. So if you see a patient who's got consolidation from atelectasis and you've done an ultrasound before the recruitment procedure and an ultrasound after the recruitment procedure, it can give us a good clue to see how many of those alveoli are opening up and how has the consolidation decreased from the atelectasis. So there's lots of things that we can use ultrasound for. What I do want to say is this is just the basics. There's much more advanced applications, but lung ultrasound is probably one of the easiest tools to pick up with regards to ultrasound. So echo, so doing basic cardiac ultrasounds, it's a more difficult skill to acquire, but lung ultrasound is really just picking up the probe and having a look. So I want to recommend you guys to practice, pick up the probe. Don't be scared to do it. Please remember that much like all things, we still need to engage our brain when we are trying to interpret what we are seeing. So a fool with a stethoscope is still a fool, much like a person who is using an ultrasound but is not putting it together with the clinical signs, still very well might be misled by focusing too much on what they're looking at. You still need to engage your brain when you're doing an ultrasound. So we like to answer yes, no questions. Is there a pleural effusion? Yes, no. Is there lung sliding? Yes, no. Is there consolidation? Yes, no. Is there a Pleural syndrome? Yes, no. Are there multiple B lines? Yes, no. Is there an A line profile? Yes, no. So still just put it together with what you're seeing when you're having a look. There's some really cool courses that you can do. You can do the emergency ultrasound course through EMSA or through AIEM. These are local courses in Johannesburg, which will take you through the basics of ultrasound and will take you through lung ultrasound as well. These are some of the cool people who've taught me a lot about ultrasound. So Victoria Stephen, Craig Beringer, Lara Goldstein, Mike Wells, Feto Simelela, Pano Parris, and Daniel Lichtenstein. I've never met him, but I've read so many of his papers. I feel like I know him. These are a lot of people who've taught me a lot